Blepharoptosis. This is me, Dr. Hatem Khattab, consultant, ophthalmologist, Zagazag University of Egypt. Bismillah ar-Rahman ar-Rahim. Blepharoptosis is defined as drooping of the upper eyelid below its normal position. Normally, the upper eyelid in the primary position covers 1 to 2 millimeters of the upper cornea. This is the linguistic origin of the term blepharoptosis. You should note that there is a difference between the word droop, which means sag or sink below its normal position, and the word drop. When we go back to basics, eyelid elevation goes into an orchestra-like manner on 3 steps. The first muscle responsible for eyelid elevation is the levator palpebris superioris muscle. Levator palpebris superioris muscle is the primary muscle responsible for eyelid elevation. It is supplied by the superior division of the oculomotor nerve. Its insertion into the upper eyelid skin produces the upper eyelid crease. The second muscle is the molars or superior tarsal muscle. The second photograph of the superior tarsal muscle or molars muscle. The last photograph of the superior tarsal muscle or molars muscle. It is an involuntary muscle comprising sympathetically innervated smooth muscle and is responsible for 1.5 to 2 millimeter elevation of the upper eyelid. The third muscle is the frontalis muscle. It acts as an accessory upper eyelid elevator. It is innervated by the facial nerve. It elevates the eyebrow as well as the upper eyelid, acting indirectly on the surrounding soft tissues. As concerns its classification, it may be divided according to the onset into congenital, which is the most important one, and acquired. Congenital ptosis is congenital maldevelopment of the levator palpebris superioris muscle, resulting in drooping of the upper eyelid since birth or within the first year of life. Acquired ptosis is abnormal drooping of the upper eyelid after 1 year of life due to any cause. Regarding possible mechanism and etiology, it may be neurogenic, myogenic, aponeurotic, traumatic, mechanical, and maybe also historical or functional. Neurogenic ptosis may be due to oculomotor palsy and may be due to Horner syndrome. This is the appearance of the patient with oculomotor palsy, and this is the typical extraocular motility pattern of left oculomotor nerve palsy.
This patient has a right third.
In Horner syndrome, there is interruption of the ocular sympathetic outflow. It has partial ptosis, miosis, and anhidrosis. This animation illustrates the ocular sympathetic outflow from its higher centers till the levator palpebrae superioris and iris dilator muscle. Myogenic ptosis may be due to myasthenia gravis and may be due to muscle dystrophy. This video illustrates the fatigability of the levator palpebrae superioris muscle on continuous up gaze. Another illustration of the fatigability of the levator palpebrae superioris muscle on continuous up gaze. This animation illustrates the abnormality at the motor end plate of the skeletal muscle. Myogenic ptosis may be also due to muscle dystrophy affecting the levator palpebrae superioris as well as the other extraocular muscles producing ophthalmoparesis or ophthalmoplegia. Amniotic ptosis may be involutional in origin and may be iatrogenic due to postoperative ptosis. Concerning the involutional variety, this is an example of bilateral involutional aponeurotic ptosis, most marked on the left side with high upper eyelid crease. Another example of severe left involutional ptosis. In the past days of surgery, we used to do superior rectus fixation suture. Many cases of them went into aponeurotic ptosis. This may be explained by the close anatomical proximity between the superior rectus muscle and the levator palpebrae superioris aponeurosis. Extensive prolonged eyelid dropping may produce aponeurotic ptosis. Prolonged rigid contact lens use may also produce aponeurotic ptosis. In aponeurotic ptosis, we have high or absent upper eyelid crease. We have thinning of the eyelid superior to the upper dorsal plate. Levator function is normal, it worsens in down gaze, and we have limited superior visual field. Traumatic ptosis may be neurogenic, aponeurotic, myogenic, or mechanical in origin. Either plant trauma or penetrating trauma could produce traumatic ptosis. We have several examples of traumatic ptosis, like these ones. Mechanical ptosis occurs due to increased weight of the upper eyelid. For example, in upper eyelid tumors or masses, upper eyelid edema, hemangioma. Blepharoptosis may be hysterical or functional in origin. Simple congenital ptosis. The cause is dysgenesis of the levator palpebrae superioris muscle. The muscle fibers are replaced by adipose and fibrous tissue. The elasticity of the muscle is lost and it is neither able to contract nor relax properly. In simple congenital ptosis, we have decreased levator function, absent or poorly defined upper eyelid crease, lid lag on down gaze, and increase in the size of the palpebral aperture in down gaze. Right simple congenital severe ptosis, right simple congenital ptosis, left simple congenital ptosis, left simple congenital ptosis, right simple severe congenital ptosis, right simple severe congenital ptosis, left simple severe congenital ptosis, right simple severe congenital ptosis, right simple severe congenital ptosis, bilateral severe simple congenital ptosis with compensatory head butcher. In simple congenital ptosis, upgaze accentuates ptosis and downgaze reveals lead leg. Regarding symptoms and the consequences, we have drooping of the upper eyelid, reduction of the visual field, and forced positions of the head and neck, eyebrow elevation, and anxiety asymmetries. Diagnosis relies upon careful case taking, stressing upon the age of onset to differentiate between the congenital and acquired varieties, any abnormal head position like chin lift, associated symptoms indicating the underlying cause. The progression of ptosis, for example, what occurs in chronic progressive external ophthalmoplegia, as well as the variability of ptosis, for example, in myasthenia gravis. Concerning symptoms of ptosis and the presenting complaint, the patient has visible drooping of one or both eyelids, cosmetic concerns, diminution of vision, and head butcher abnormality. Movement of the eyelid with the movement of the mouth. This is called jaw winking phenomena. Some patients have double vision in upgaze if congenital ptosis was associated with superior rectus abnormality. Past medical history is very important, especially for trauma, whether blunt or penetrating, myasthenia gravis, myotonic dystrophy, chronic progressive external ophthalmoplegia, muscle dystrophy, hypertension, thyroid disorders, diabetes, recurrent episodes like recurrent third nerve palsy due to diabetes or hypertension, amblyopia therapy, glasses prescription, previous drug intake, bleeding tendencies, past surgical history, especially for strabismus surgery and ptosis surgery. Birth history, whether prenatally, natally, and neonatally. Forceps delivery can be associated with an injury resulting in ptosis or facial palsy. Family history is very important, especially in blepharoptosis ptosis syndrome. As regards physical examination, family album revision is very important to determine the duration, severity, or variability of ptosis. Handshaking is very important to rule out myotonic dystrophy. Best corrected visual acuity is important to rule out any associated refractive errors or amblyopia. Facial symmetry, abnormal head posture. On the left side, you can notice the compensatory head posture in severe bilateral congenital ptosis, and on the right side, the improvement in the head posture after successful surgery. Frontalis overaction is a compensation. The extraocular motility in the cardinal directions of gaze. Cover and uncover tests. Direct and consensual light reflex. Jaw winking phenomena. Best corrected visual acuity. Fundus examination. It's very important to exclude pseudo-ptosis. Pseudo means false ptosis. False ptosis or pseudotosis may be due to enophthalmos, maybe due to atrophia palpi, microphthalmos, small facial eye. Pseudotosis may be due to contralateral lid retraction. This is a summary of the causes of pseudotosis, whether ipsilaterally or contralaterally. We have special measurements. The first one is the marginal reflex distance, which is the distance between the upper lid margin and the light reflex in the pupil in the primary position. The upper eyelid excursion, it is measured in millimeters from extreme down gaze to up gaze with the brow neutralized by the examiner's hand. Pressure on the eyebrow is done to nullify the action of the frontalis muscle. Another photograph of the upper eyelid excursion or levator function. The results are graded from poor to excellent. The palpebral fissure vertical height is measured in between the margin of the lower lid to the margin of the upper lid. This is the normal measurements in males and females. Jaw winking phenomena is an associated sign because is faulty innervation between the oculomotor nerve supplying the levator palpebrae superioris muscle and the mandibular branch of the trigeminal supplying the muscles of mastication. This is the linguistic origin of the term wink. Wink means close and open one eye quickly. Superior rectus weakness may be associated with many cases of congenital ptosis. The blepharoptosis ptosis syndrome. Bell's phenomena is a very important clinical sign. Bell's phenomena is a normal defensive reflex of the eye, wherein on closing the eyelids, the eye moves upwards and outwards. This is an illustration of a normal Bell's phenomenon. It's graded between good, fair, and poor. This is an example of good Bell's phenomena. On the other side, this is a poor Bell's phenomenon. It's very important to notice that all patients should be examined for the phenomena to assess the possible risk of corneal exposure after surgery. Testing corneal sensation is very important. Testing for lagophthalmos and tear film quality and the quantity is very important. Ancillary testing depends upon the provisional diagnosis. For example, in myasthenia gravis, we may perform eye spec test, safe, easy, and specific and sensitive test for diagnosis of myasthenia gravis. Eye enhances neuromuscular transmission and will help to diagnose many cases of myasthenia gravis. The sleep test also is very important to diagnose myasthenia gravis. Acetylcholine receptor antibody test, single fiber electromyography, as well as hydrophonium or tensilon testing. Phenylephrine testing is performed in patients with minimal ptosis. The main value is to indicate that Moller's muscle is viable, so operation to resect Moller's muscle and conjunctiva can relieve ptosis. Surgical treatment of blepharoptosis. When we go back to basics, we have three tools to operate in blepharoptosis: the levator palpebrae superioris muscle, the Moller's muscle, and the frontalis. In congenital ptosis, surgery is performed according to the severity. In these cases with severe ptosis, surgery should be performed as early as possible to avoid stimulus deprivation and amblyopia. In cases with milder ptosis, we usually postpone till 5 years because technique performed to determine the levator action is painful and invasive and can be performed easily in younger children. Also to avoid psychological problems on facing other kids on entering school. The other factor determining the timing of surgery, degree of levator action. In acquired ptosis, we perform surgery when treatment of the cause has failed or is impossible. It's very important to note that surgery may be hazardous in cases with third nerve palsy with diplopia, cases with corneal anesthesia, and in cases with absent Bell's phenomenon. What are the surgical techniques performed to correct blepharoptosis? Fasanella servat operation is indicated in mild ptosis due to Moller's muscle weakness. It involves resecting Moller's muscle through a conjunctival approach. This is an illustration of Fasanella servat procedure indicated for mild ptosis with good levator function. Another illustration of Fasanella servat procedure, and the last illustration of the same procedure. When the levator function is good, levator resection is the treatment of choice. Principle is when these rubber bands get stretched, they become stronger. Levator resection is a strengthening procedure for the levator muscle. This is an illustration of levator muscle resection. Another illustration. The approach can be either anterior skin approach, which is called ever-push approach. This is an illustration of the anterior skin approach for levator resection. Another illustration of the same technique. Or maybe through the conjunctival approach, what is called Blaskovic's technique or approach. This is an illustration of Blaskovic's transconjunctival approach for levator resection. The third tool, the frontalis muscle, we can do the frontalis sling surgery. What is sling? This is the linguistic origin of the term sling. It's indicated in cases where the levator function is very poor. Also, it is indicated in severe Marcus-Gunn-Joe syndrome, Blepharoptosis syndrome, oculomotor palsy, and traumatic levator injury with levator function less than 4 mm. Different sling configurations. Many materials could be used. The fasciolata, Marceline mesh could be used. Silicone rods could be used. Silicone rods. Vortex. This is a summary of the different techniques that could be used for blepharoptosis. Other techniques. In mechanical ptosis, the treatment of choice is treatment of the cause. In cases with aponeurotic dehiscence, aponeurotic advancement is performed. It's an illustration of anterior levator aponeurotic repair. For communication, this is my WhatsApp number and this is my email. Don't forget to like this video, subscribe, enable notification, share, and comment. This is the Facebook page, the Telegram channel. Thank you and have a nice day.